So next topic is malrotation. It's a V25. So it's a 3-week-old term baby girl with a weight of 4.5 kilogram was seen in emergency department with green vomiting in the last 2 days, became drowsy and was admitted with severe dehydration. Nasogastric tube drained bilious fluid. She is asleep, cold in the periphery with a capillary fill time of 5 seconds. What will be your priority and what differential diagnosis are you thinking? So my priority is to manage resuscitate the patient with advanced pediatric resuscitation APLS protocol. Patient sounds profoundly dehydrated and she needs a fluid. We will give a saline 0.9%, 20 ml per kg as a fluid. And the cause of bilious vomiting in infant can be either medical or surgical. And the surgical could be high obstruction, including malrotation, volvulus, and jejunal obstruction, and low obstruction, inguinal hernia, Hirschsprung disease with enterocolitis, mixed endocrine malformation. How would you differentiate high from the low intestinal obstruction? So history and the X-ray. So high bowel obstruction typically results in the large amount of green aspirate vomiting associated with a flat or scarified abdomen with or without gastrification. Radiological features are gastric or duodenal dilatation followed by change in the caliber to the collapsed or glassless bowel distal to that. Large bowel obstruction typically presents with non-bilious vomiting to begin with and ended up with a biliary vomiting. The abdomen is distended. Radiological features are dilated loops throughout the abdomen with occasional absent pelvic. Yes, how will you confirm the diagnosis of malrotation? So we need GI contrast study to identify the position of the DJ. In normal rotation, DJ is on the left of the midline at the level of the pylorus and on anterior posterior fluoroscopy, with duodenal courses posteriorly on the lateral fluoroscopy. And individual malnutrition predisposes the risk of midgut volvulus comprising blood flow to the mesenteric vessels and causing venous congestion followed by ischemia. If volvulus occurs, the upper GI study will show a corkscrew appearance. And on these studies, if the DJ is not on its normal left side and the whole proximal bowel is in a corkscrew appearance, it's a malrotation. What congenital anomalies lead to the abnormal position of the DJ? So it's anterior abdominal wall defects, which are in the form of gastroschisis, exomphalos, congenital diaphragmatic hernia. Although DJ flexure in these three conditions remain in the same position, but still they can develop obstruction, which is called non-rotation. Embryologically, anterior wall defect and congenital diaphragmatic hernia may result in the failure of the midgut to return into the fixed abdominal cavity following a physiological herniation between 6 to 10 weeks of the gestational life. Therefore, DJ and cecum might not have been fixed to the retroperitoneum on the left and the right lower quadrant respectively. So what is the incidence of malrotation and when do they present? So incidence is 0.5 to 4%, but incidence symptomatic malrotation 1 into 1000, 3000, 64% people present in the first 3 months. What procedure is required in the patient with malrotation volvulus? So it's LADS procedure. Following a laparotomy, laparoscopy, the midgut is untwisted counterclockwise to leave the volvulus. LADS bands are divided to relieve the duodenal obstruction. The duodenum is straightened and the midgut mesentery is free to enable the cecum to be placed in the left upper quadrant of the abdomen while keeping the DJ in place, therefore widening the mesentery to mitigate the risk of future volvulus. Thank you.